we are having a bit of a technical problem in our president of the society unable to join. So I will have to start. I hope you all can hear me. First of all, let me thank. The Sri Lanka Society of Gastroenterology for the kind invitation to deliver this lecture. This is a topic which is neglected, and I'm happy that Dr. Pulisha Pudising suggested this topic. And today I'll be talking on chronic nausea and vomiting, diagnostic approach. So I have no relevant conflicts of interest to declare with regards to this presentation. The objective of today's talk is to illustrate a typical case of chronic nausea and vomiting, discuss the pathophysiology and differential diagnosis of chronic nausea and vomiting. I'll try to describe the common tools currently used for the diagnosis of specific conditions causing chronic nausea and vomiting, and also lastly, touch upon the treatment modalities utilized in managing chronic nausea and vomiting in the present context. I'll start off with a case history. This is a 20-year-old male from Dampa who's unemployed, awaiting university entrance on the physical sciences stream. There was no significant medical history. He presented with recurrent nausea and vomiting, abdominal pain, and 4 kilograms of weight loss over the past 3 months. He had multiple emergency treatment visits, 4 visits, in fact, and 2 short hospital stays for recurrent vomiting. These episodes lasted for several days and was characterized by severe nausea with vomiting around 8 to 10 times a day with abdominal pain. These episodes lasted approximately 3 days with full recovery in between the attacks. He was quite well in between the attacks, and in the presence of the mother, admitted to only occasional safe alcohol use and occasional cigarette smoking. On examination, his temperature was normal. The abdomen was tender only to palpation in the upper quadrant in the gastrium. Blood pressure was normal and pulse rate was also normal. Neurological examination was negative for focal neurological deficit with no papilledema. His investigations revealed normal liver biochemistry and other hematological parameters, including hemoglobin, white cells, platelets, renal biochemistry, other basic metabolic panel, and blood glucose is normal. His ultrasound scan abdomen did not show any gallbladder disease or pancreatic disease. A CT scan of the head was performed, and that was also normal. An upper gastrointestinal endoscopy was performed, and it showed gastropathy with positivity for H. pylori on rapid urease testing. Despite H. pylori eradication for 2 weeks and supportive therapy, the patient continued to have recurrent nausea and vomiting and presented with typical episodes. So how should we evaluate and manage this patient? So before coming into our patient again, let us clarify some terms and definitions. Vomiting is associated and has to be differentiated from similar symptoms. Nausea is accompanying vomiting most of the time, and nausea is defined as a vague, painless, unpleasant, subjective feeling of imminent need to vomit. May or may not be followed by vomiting itself. Vomiting is characterized by a forceful ejection of gastric or intestinal contents from the mouth, and it is associated with rhythmic contractions of the abdominal wall and diaphragm. Regurgitation is different in that it is characterized by effortless and involuntary movement of gastric contents into the mouth without the absence of abdominal and diaphragmatic muscle activity. And rumination is also different from vomiting in that it's an involuntary process in which patients effortlessly bring up recently ingested food from the stomach into the mouth within minutes of eating or during eating, to a voluntary increase in abdominal pressure, where it is often chewed and reswallowed. Now, vomiting, nausea and vomiting can be either acute or chronic. The acute nausea and vomiting, which I will not be discussing today, is generally defined by symptom duration of 7 or less days. The most common cases represent either a transient medical condition like gastroenteritis or a self-limited somatic disorder like a myocardial infarction or medication side effects such as chemotherapy or anesthetic drugs. The topic today, chronic nausea and vomiting, is defined by symptom duration lasting 4 weeks or more. So it's 1 month or more. And the cases can be either gastrointestinal, mucosal disease, obstructive, hepatobiliary pancreatic, or motility disorders, or it can be non-gastrointestinal, drug-induced, neurologic, vestibular, hormonal endocrine, or metabolic, or psychiatric diseases. Let us touch upon the epidemiology and the impact of chronic nausea and vomiting. The epidemiology of chronic nausea and vomiting is not very well known. From studies, we know that chronic nausea and vomiting can affect 7% of the population. And out of this, the most widely characterized disease entity is gastroparesis, which can affect 4 to 5% of the population. And quality of life is reduced in these patients with chronic nausea and vomiting. And the best data, again, is derived from studies on gastroparesis. Pathophysiology of chronic nausea vomiting is complex. The central center for nausea vomiting is located in the medulla, and it gets inputs from the cerebral cortex, and various other inputs come from the chemoreceptor trigger zone, the vestibular system, the gastrointestinal tract, the oropharynx, and the musculoskeletal system, and all these are transmitted via a nucleus tractus solitarius, again located in the medulla. And vomiting can be triggered by drugs, chemicals, and toxins through the chemoreceptor trigger zone. Vomiting can also be triggered by surgery, chemotherapy, and food poisoning through the nucleus tractus solitarius. And the nausea and vomiting center itself can be directly triggered by fear, anticipation, pain, and olfactory factors. And you can see a wide variety of neurotransmitters are involved in this pathophysiology. And the main neurotransmitters implicated are dopamine and 5-HT3 in the chemoreceptor trigger zone, and histamine and muscarinic receptors in the nausea and vomiting center. And this is important in the drug management of chronic nausea and vomiting. When we come to the etiology, there are a wide variety of gastrointestinal disorders that can cause chronic nausea and vomiting, and the organic disorders, as opposed to the functional or disorders of gut-brain interaction, are classified as mucosal inflammation, mechanical obstruction, hepatobiliary pancreatic, or motility. Mucosal diseases include peptic ulcer disease and Crohn's disease. Mechanical obstruction can be at the level of the esophagus, gastric outlet, or small bowel. Hepatobiliary pancreatic diseases include chronic hepatitis, infiltrative diseases of the liver, partial biliary obstruction or chronic pancreatitis, and motility disorders include achalasia, gastroparesis-like syndrome, and intestinal pseudo-obstruction. There are a few gastrointestinal disorders which can be functional in the absence of organic causes. We tend to avoid the term functional now and describe these as disorders of gut-brain interaction. And the first group of disorders are the functional dyspepsias, which can have chronic nausea, vomiting as an accompanying symptom, but their main clinical features would be that of other symptoms such as epigastric pain or burning, or postprandial fullness in the epigastric pain syndrome, or postprandial distress syndrome. So chronic nausea vomiting can be a part of functional dyspepsia. But it is the main symptom in the other group of these gastrointestinal disorders. The main 3 disease components here, according to the Rome 4 classification, are the cyclic vomiting syndrome, chronic nausea and vomiting syndrome, and cannabinoid hyperemesis syndrome. We'll touch upon these diseases later in the talk. The non-gastrointestinal disorders can be due to a variety of causes. They can be due to medications and toxins, opioids, NSAIDs, hormones, digoxin chemotherapy, metabolic and endocrine disorders such as pregnancy, diabetes with hyperglycemia, uremia, adrenal insufficiency, and thyroid diseases. And CNS and vestibular diseases include migraine, seizure disorders, Parkinson's disease, brain lesions and vestibular disorders, and psychiatric diseases include eating disorders such as anorexia, bulimia, and conditioned vomiting. In the evaluation of chronic nausea and vomiting, the initial diagnostic evaluation should involve distinguishing GI causes of chronic nausea and vomiting from the non-GI causes. So that is the first step in the initial diagnostic evaluation. And further evaluation includes, after excluding anatomic, mechanical, and biochemical causes of chronic nausea and vomiting, these GI causes can be broadly divided according to the gastric emptying, whether the gastric emptying is normal or whether the gastric emptying is delayed. So the diagnostic approach predominantly has to be concentrated on the history. A good, focused, relevant history is the most important in evaluating in this patient, supported by a physical examination and very selective investigations. And specific investigation should be guided by the preceding history and should be tailored rather than each patient empirically undergoing a blanket of investigation. So these patients should not be over-investigated, and the selective investigation should be guided by a very good history. And here are some features that would suggest to a specific cause in the history. We should differentiate vomiting from regurgitation. Forceful expulsion suggests vomiting from the stomach. Passive regurgitation suggests esophageal disorders. And the initial onset, progression, and duration of the disease is also important, because insidious onset of nausea is suggestive of gastroparesis, medication side effects, metabolic disorders, pregnancy, or reflux disease. And description of the vomitus should be established clearly, because regurgitation of undigested food is suggestive of esophageal disorders. Vomiting of partially digested food several hours after a meal suggests that there is delayed gastric emptying or gastric outlet obstruction. Bilious vomiting is suggestive of a small bowel obstruction, and fecal vomiting is suggestive of more distal intestinal obstruction. And timing and description of the vomiting is also important. And vomiting in the morning before breakfast is suggestive of either pregnancy, uremia, alcohol ingestion, or raised intracranial pressure. And projectile vomiting in the absence of nausea is suggestive of raised intracranial pressure. Vomiting during or soon after meal is suggestive of rumination, anorexia, or bulimia like eating disorders. Whereas postprandial vomiting an hour or later is more suggestive of functional dyspepsia, gastroparesis, or gastric outlet obstruction. And remember that episodic, severe, unrelenting episodes of vomiting is suggestive of cyclical vomiting syndrome and cannabinoid hyperemesis syndrome, where the patient has episodes of vomiting and in between the patient is well. And other associated symptoms are also important in differentiating the causes. Early satiety and postprandial fullness is suggestive of gastroparesis. Abdominal pain may be suggestive of underlying biliary or pancreatic disorder. Severe colicky pain may improve after vomiting is suggestive of, which may indicate small bowel obstruction. Weight loss in the presence of malignancy, gastroparesis, or gastric outlet obstruction. And carefully look for CNS symptoms such as headache, vertigo, and focal neurology as a central cause of nausea and vomiting. Physical examination should be directed to identify signs of weight loss and dehydration. So document the BMI, look for signs of cachexia. A postural drop in blood pressure and an increasing heart rate on standing suggests that there is dehydration and volume loss. Whereas a decreasing in blood pressure on standing without any change in heart rate suggests autonomic neuropathy, which may contribute into nausea and vomiting. General examination should look for jaundice, presence of lymphadenopathy, loss of dental enamel, features of paratoxicosis, Addison's disease, and features of scleroderma. Abdominal examination should look for masses, suction splash, tenderness in the gastrium or the right upper quadrant, and increased or absent bowel sound, increased bowel sounds in obstruction, absent bowel sounds in paralytic ileus. And neurological examination should look into the gait, the optic nerve, the fundi, cranial nerves, and the long tracts. Blood tests should identify the consequences of vomiting. A renal profile should look into acute kidney injury. Serum electrolytes should look into hypokalemia and blood gases. Will reveal hypochloremic metabolic alkalosis. And other investigations to identify the underlying causes such as full blood count, inflammatory markers, complete metabolic profile, including the liver, renal, thyroid functions, glycemic control in diabetics, and if indicated, serum drug and toxicity levels. Tests for obstruction and mucosal abnormalities for GI causes include a simple abdominal X-ray, supine and upright. This may suggest obstruction or the presence of calcification in chronic pancreatitis. But remember that 22% of patients with partial small bowel obstruction will not show any signs features on the abdominal X-ray. Upper GI radiographic series or a small bowel follow-through barium study may reveal obstruction and mucosal disease of the upper GI tract, may also show superior mesenteric artery syndrome in some patients. The abdominal CT may be useful to detect and diagnose the cause of obstruction and also look at other intra-abdominal organs. An upper GI endoscopy is invaluable in examining the esophagus, gastric, and duodenal mucosa, and we can also take biopsy specimens. There are specific tests to look at GI motility, and gastric emptying tests are the most frequently used ones, and these include scintigraphy, breath test, and wireless motility capsule. We can quantify the gastric emptying of solids and or liquids with this and identify patients who have normal gastric emptying with chronic nausea vomiting and those with delayed gastric emptying with chronic nausea. And there are specialized tests for gastric function which are not available in Sri Lanka. That's enteroduodenal manometry, EEGs, and gastric accommodation and sensation tests such as gastric balloon barostat, abdominal MRI, to quantify the accommodation and intragastric meal distribution during delivery. And these are used very rarely in really refractory patients where we can't really find the cause. And gastric emptying tests are most commonly used. And we should not forget CNS imaging if indicated to evaluate CNS lesions, either CT or an MRI of the head to exclude a central lesion as a cause of chronic nausea and vomiting in appropriate patients. A bit more on the gastric emptying tests. The gastric emptying scintigraphy or GES is non-invasive. It's physiological, standard, most reliable test of gastric emptying, where the patients ingest a radio-labeled technetium-99 low-fat egg beater meal, basically a scrambled egg meal. And emptying of the stomach is monitored over time by serial images using a gamma camera. And for solid phase gastric emptying scintigraphy, after 4 hours, if there is retention of more than 10% of contents, usually all the gastric contents are emptied at 4 hours. If there is residual this ingested radio-labeled material, that indicates delayed gastric emptying. The alternative is to use a non-radioactive carbon-13 bound digestible substance. After ingestion, stomach emptying is absorbed in the small intestine and metabolized to release carbon-13 carbon dioxide, then expired into the lung. And breath testing can detect this non-radioactive carbon-13, and it has good sensitivity in detecting gastric emptying, but not as good as scintigraphy. So stabilized isotope, non-radioactive breath test also can be used. And wireless motility capsule has also been tried, and it's an ingestible capsule that measures not only the gastric emptying, but the pH, the pressures, the temperatures, using miniaturized wireless sensor technology and gastric resident time. The time that the capsule retains in the stomach is indicative of the gastric emptying, and it compares well with the other two varieties of studies. And this also can assess small bowel and colonic transit, not only the gastric emptying. I must say that when we are sending these patients for these tests, the medication that can affect the gastric emptying should be stopped for 48 hours before this testing. And diabetic patients should have the hyperglycemia controlled, because hyperglycemia itself can reduce the gastric emptying. So if we want to get the accurate measurement, the blood sugars should be controlled first, and then the patient should be sent for testing. Here is an example of a technetium scintigraphic study. On the left panel, there is a normal gastric emptying. You can see at 4 hours, all the contents have been emptied, whereas on the right panel, there is delayed gastric emptying. 57% of the ingested meal is still retained within the stomach, and this is severe delayed gastric emptying. For us, scintigraphy is not readily available, but what is available is real-time ultrasound, and ultrasound methods have been compared with other methods and proven to be an accurate method to assess gastric motility. It has been compared against scintigraphy as well as carbon-13 breath testing. So what we do is actually we give a standard liquid meal, and the patient takes it, and we measure the gastric antrum using a standard ultrasound probe, measure the surface area of the gastric antrum at 1 minute and 15 minutes, and we calculate the gastric emptying according to this formula. And this is what is done for our patients in the Department of Physiology in Calgary. Tests for gastric motility and accommodation, I told that this test will be used in only a minority of patients, and Gastroduodenal manometry, EEG, and barostat inspect and MRI. I won't be touching on these investigations due to time constraints and non-availability. When an underlying cause has not been identified after careful history, physical examination, and selective testing, patients with persistent symptoms of nausea and vomiting should always be evaluated for eating disorders such as anorexia and bulimia. And patients who fail repeated courses of empirical therapy for chronic nausea and vomiting with negative diagnostic evaluation again should be evaluated for an eating disorder. So remember, when we can't identify an underlying cause and empirical therapy repeatedly fails to subside their symptoms, we should think of eating disorders in these patients and get an appropriate psychiatric evaluation. And patients at high risk of these eating disorders are young women in competitive athletics, those with first-degree family members with eating disorders, and those with significant anxiety, underlying depression, body image disorders, or sexual orientation or gender expression disorders. When an underlying cause has not been identified after careful evaluation in the history, physical examination, and testing, and patients with persistent nausea and vomiting also should be evaluated very carefully for substance abuse, including cannabis. And cannabinoid hyperemesis syndrome is not uncommon. We are seeing patients now, and they usually have weekly cannabis use, most of them, and very characteristic of some of them to describe hot water baths to relieve the nausea and vomiting. Coming to some specific causes of chronic nausea and vomiting, gastroparesis is the most common specific cause. And if neither an obstruction nor mucosal disease is evident on the evaluation, an underlying motility disorder such as gastroparesis should be considered. Gastroparesis is a motility disorder of the stomach. It's characterized by slowed emptying of food into the small intestine in the absence of mechanical obstruction. Therefore, the diagnosis of gastroparesis is based on 3 things: compatible symptoms, the absence of obstruction or mucosal disease, and a demonstrable delayed gastric emptying. Patients with gastroparesis present with a variety of symptoms, and most frequently, the encountered symptoms include nausea, vomiting, abdominal bloating, and abdominal pain. This is mostly postprandial. And long-term gastroparesis is also associated with stasis and consequences of repeated vomiting, such as esophagitis, narrow-device stairs, and peptic ulcer disease. There are multiple scoring systems available to assess the severity of gastroparesis, and some of these include the Gastroparesis Cardinal Symptoms Index, or GCSI, and the Bell scoring system. Documentation of delayed gastric emptying is recommended before prescribing therapy, either pharmacological or non-pharmacological. Patients should undergo biochemical screening for diabetes and hypothyroidism and other tests as indicated clinically. And the causes of gastroparesis, the majority are idiopathic, and some of them may be diabetic, drug-induced, or post. Nausea is present in virtually all patients with gastroparesis. Vomiting is most common with diabetic gastroparesis. Coming to the functional gastroduodenal causes of chronic nausea and vomiting, there are three. Rome-4 classification describes three disease entities: chronic nausea and vomiting syndrome, cyclical vomiting syndrome, and cannabinoid hyperemesis syndrome. And chronic nausea and vomiting is defined by bothersome nausea occurring at least 1 day a week, one or more vomiting episodes a week. Self-induced vomiting, eating disorders, irritation, rumination must be excluded, and there should be no evidence of organic, systemic, metabolic diseases that is likely to explain the symptoms on routine investigation. And the criteria should be fulfilled for the last 3 months with symptom onset at least 6 months before the diagnosis. And cyclical vomiting syndrome is characterized by at least discrete episodes in the prior year and 2 episodes in the past 6 months occurring at least 1 week apart. There should be absence of vomiting in between episodes, but they can have minor symptoms. And the stereotypical episodes of vomiting, profuse, very severe episodes of vomiting should be there. There can be a family history of migraine headaches. 1/3 of adults become disabled, and this accounts for about 10% of unexplained chronic nausea and vomiting. And cannabinoid hyperemesis syndrome is characterized by stereotypical episodic vomiting resembling CVS in terms of onset, duration, and frequency. Presentation is after prolonged excessive cannabis use, and there is relief of vomiting of these episodes by sustained cessation of cannabis use. And it may be associated with pathologic behavior such as hot baths and showers to relieve symptoms. And again, criteria should be fulfilled for the last 3 months with symptom onset at least 6 months before the diagnosis. So coming back to our patient, the gastric emptying scintigraphy, or rather it was planned, but it was not available. We had to wait for the isotope. So we were planning actually an ultrasound gastric emptying study and a CT scan of the abdomen with enteroclysis to look for any small bowel disease. But a detailed history in the absence of the mother revealed that the patient has begun smoking cannabis at the age of 18 years. And at present, he was smoking about 2 to 3 cannabis cigarettes daily. And a cannabinoid hyperemesis syndrome was highly suspected, given the recurrent episodes of severe nausea and intractable vomiting, abdominal pain, and daily habitual use of cannabis. So how should we manage these patients? Management of chronic nausea and vomiting should include first the recognition and correction of any consequences and complications of nausea and vomiting. Secondly, identification whenever possible of an underlying cause or causes, followed by appropriate therapy for those individual causes. And thirdly, where necessary, therapeutic strategies to suppress or eliminate the symptoms. Management of chronic nausea and vomiting, with few exceptions, is generally very similar to that of gastroparesis. And validated treatment algorithms do not exist, and treatment should be based on thoughtful discussion of the benefits, side effects, and the cost of these treatments. The overall management of such patients and selected therapy can be guided by the degree of gastric emptying delays and the response to treatment. Here is a rough guide how we should use the general measures, the dietary modifications, the nutritional support, the pharmacological therapies such as prokinetics, anti-emetics, and symptom modulators, and non-pharmacological methods in treating mild, moderate, and severe gastroparesis. Gastroparesis is classified here as mild when it's retention at 4 hours is about 10 to 15%, it's mild, 15 to 35 is moderate, and more than 35 is severe. I'll take each of these components individually and discuss. In the general measures, the first line management of gastroparesis patients should include restoration of fluid, electrolyte, and nutritional support. That's paramount to look at these patients, correct the dehydration, correct the electrolyte imbalances, correct the caloric deficiencies, and the vitamin and mineral nutrient deficiencies. Concomitant medications that decrease gastrointestinal motility should be discontinued, such as opioids, dopamine agonists, calcium channel blockers, alpha-2 adrenergic agonists, and muscarinic cholinergic antagonists. Glycemic control is important because acute hypoglycemia can slow gastric emptying, and optimization of glycemic control, especially in diabetes, should be a target of therapy. Smoking and alcohol can delay gastric emptying, so therefore they should be avoided. Abstinence is important. Diet and oral nutrition is important. Poor oral intake may result in deficiencies of calories, vitamins, and minerals. Oral intake is always preferable in these patients, despite of nausea and vomiting. And patients with mild gastroparesis actually can be managed with small, frequent meals that are low in fat and low in non-digestible fiber, because fat and non-digestible fiber reduce gastric emptying. And if we cut out these and make the meals small and frequent, the patients might tolerate. And blenderized, homogenized solids or liquid nutrient meals can also be tried, because in some patients, the solid gastric emptying may be delayed and the liquid gastric emptying may be normal. Enteral nutrition is always preferred. If oral intake is insufficient, then enteral alimentation by jejunostomic feeding tube can be pursued, and this is after a trial of nasoenteric tube feeding tolerated. We can go for a permanent jejunostomy feeding tube. Jejunostomies can be placed via endoscopic, radiographic, or laparoscopic surgical procedures. Indications include unintentional weight loss of more than 10% within the past 3 months and or repeated hospital admissions with refractory symptoms. And jejunal feeding is always preferred over parenteral nutrition due to its lower potential for complications, reduced cost, and ease of delivery. Coming to medication, there is a robust need for clinical appraisal of all these therapies, including medications in patients with chronic nausea and vomiting, with or without gastroparesis. And the formulations can be either liquid, oral dissolving, or transdermal, because these anti-emetic medications, if we give them in these formulations, they will maximize the absorption and optimize the pharmacokinetics. Coming to the first group, Prokinetics, they promote the broad movement of luminal contents through increased contractility of the gastrointestinal tract. They increase the antral contractility. They correct the gastric dysrhythmias, the bradygastria or the tachygastria, and improve coordination between the antrum and the duodenum. So increases the gastric emptying into the small bowel. Prokinetic therapy should be considered to improve gastric emptying and gastroparesis symptoms, but we must take into the benefits and the risk of these treatments, because these drugs do have side effects. In gastroparesis, erythromycin was the most effective in improving gastric emptying. Both erythromycin and domperidone improved overall symptoms. And here are the main groups of drugs, the prokinetic drugs. Firstly, we have the dopamine receptor antagonists. We have 2 drugs, metoclopramide and domperidone. Metoclopramide acts peripherally and centrally. Peripherally acts via the D1, D2 receptors, and centrally acts via the 5-HT4 receptors. It is the first-line treatment and the only treatment approved by the FDA, but it has major adverse effects. It crosses the blood-brain barrier and causes CNS side effects, tardive dyskinesia in less than 1%, depression also, and it causes cardiac side effects such as prolonged QTC. Domperidone, on the other hand, only has peripheral action via the D2 receptors. It does not cross the blood-brain barrier, so no CNS side effects, but it has prominent cardiac side effects. So we need a baseline ECG before prescribing domperidone long term, and it can cause prolonged QTC, arrhythmias, and sudden cardiac death. So both these drugs should be used in the lowest possible dose or the shortest possible duration. Then we also have the motility receptor antagonists, and the most widely described one is erythromycin. The motility receptor antagonist that stimulates the enteric cholinergic nerves and smooth muscle directly. It's an IV prokinetic therapy of choice for patients with who are hospitalized with severe symptoms. Very effective when given IV, but long-term effectiveness of oral therapy is limited by tachyplasty, because these patients develop tolerance, and because of the antibiotic activity, it can lead to complications like CD. So oral erythromycin is not recommended, but IV certainly for patients who are hospitalized with severe symptoms. Then we have 5-HT receptor agonists. The newer one is procalypride. It releases acetylcholine from myenteric neurons, resulting in smooth muscle contraction and accelerated gastric emptying. And the advantage here is this can be used long term because it does not have any cardiac side effects and it does not have any CNS side effects. Then we have the last group is ghrelin receptor agonist, and the best example is relomeredin. It increases gastric emptying, improves meal-related symptoms in both idiopathic and diabetic gastroparesis. So the new kids on the block, the procalypride and the relomeredin, is very useful because of their lesser side effect profile and effectiveness. Then we come to the anti-emetics. They are required for management of nausea vomiting. Commonly prescribed agents are phenothiazines. An example is chlorpromazine. Antihistamines like cyclacine and promethazine, and 5-HT3 antagonists such as ondansetron and ganisetron. These are the most commonly prescribed antiemetics. Less commonly prescribed ones would be dronabinol and nabilon, which are cannabinoids, which are approved for the treatment of chemotherapy-induced nausea and vomiting. And we must be mindful that prolonged use of these agents also can result in cannabinoid hyperemesis syndrome and paradoxically worsen the nausea and vomiting. And there is a neurokine 1 receptor antagonist, which is aprepitant, which is also widely used in the treatment of chemotherapy-induced nausea. In management of the abdominal pain, this is an important issue because most of these patients have postprandial abdominal pain, and the drugs that can be used are mirtazapine and gabapentin. And mirtazapine helps ameliorate symptoms, especially nausea and vomiting in individuals with both gastric, diabetic, and non-diabetic gastroparesis. And low-dose gabapentin may improve visceral pain in these patients. But opioids should be avoided with the potential to worsen the nausea and vomiting. So coming to the non-pharmacological therapies, the pyloric and other surgical intervention, and pyloric spasm has been observed in these patients with gastroparesis. And pyloric interventions can be beneficial in patients who have demonstrable pylospasm. And endoscopic procedures such as Botox injection or GPOM or surgical interventions such as pyloroplasty may be helpful in selected patients. The success of pyloric intervention may be predicted by the preservation of antral motility activity, which can be measured by various methods. The assessment of pyloric cross-sectional area and compliance with endoflip, which is something similar to high-resolution manometry, using a catheter to measure the cross-sectional impedance, can be used in the pyloric region to characterize pylospasm. So if patients are having delayed gastric emptying symptoms but poor response to medical treatment, with pharmacological and non-pharmacological, which we have described so far, we can either do gastroduodenal manometry or endoflip to characterize the pylospasm. If we don't have that, we can actually try a trial of Botox injection, and if there is a good response, we can send those patients for endoscopic or surgical pyloric intervention. If there is poor response, then we can intensify medical management and suggest jejunal feeding with concomitant PEG drainage. And very rarely, very refractory cases will need parenteral nutrition. What about gastric electrical stimulation? This is FDA approved for refractory diabetic and idiopathic gastroparesis. There is limited control studies. It does not normalize gastric emptying, and some data to suggest that there is improvement of symptoms in refractory cases. There are complementary and alternative therapies also. A number of complementary and alternative therapies are used to treat symptoms of chronic nausea and vomiting, regardless of the underlying cause. Data from large randomized placebo-controlled trials are lacking for most of these agents. Some of these small studies have described benefit of electroacupuncture and ginger. And some of these drugs, ibogaine and hypnotherapy. And ginger in powdered root form, 250 milligrams after meal and bedtime, has shown some evidence in multiple studies. A little bit on cyclical vomiting syndrome. Um, we know the diagnostic criteria from the Rome 4 consensus. This can be mild or moderate based on the number of episodes, less than 4 or more than 4 per year. The episodes being brief, less than 2 or more than long. And the quickness of recovery from these episodes, whether it's quick or long, and the need for hospital admission and ED visits. So if it's mild, we can manage with abortive therapy, triptans, ondansetron, phenothiazine, or antihistamines. There is some evidence for coenzyme Q10, and moderate to severe episodes should be managed with abortive therapy plus prophylactic therapy with tricyclic antidepressants and also paramedic. So coming back to our patient, multiple sessions of supportive psychotherapy was provided via the psychiatric team to our patient, and he was encouraged to quit cannabis. The patient reported less nausea, vomiting, and abdominal pain after 1 month of decrease in the daily use, and the symptoms completely resolved after cessation of cannabis use. This was 2 months after starting the psychiatric. And at 6 months follow-up appointment, the patient was completely asymptomatic. So, ladies and gentlemen, in summary, chronic nausea and vomiting is a common problem that develops for a diverse array of reasons, both GI and non-GI. Clinicians need to act as a skillful detective. Teasing out key characteristics of the history is very essential and will eliminate unnecessary testing and inappropriate medications. And after excluding structural and organic causes for the symptoms of nausea and vomiting, identify patients with late gastric emptying is useful, and it frequently influences the therapy. Early initiation therapy is important that may minimize the complications of chronic nausea and vomiting, such as hyperpatholosis, hyperkalemia, malnutrition, and scans. Supportive medical therapy should be individualized based on the previous trial of these medications. Careful discussion with the patients regarding the potential risks, the benefits, and the costs. Combination therapy is useful for many patients, although prospective studies evaluating this are not available. And novel pharmacotherapy, which we have discussed, glucalapride and relamorelin, are promising with much less side effects and the potential to be used long-term, and endoscopic and laparoscopic interventions may also change the landscape of therapy for gastroparesis and treatment of chronic nausea and vomiting. This is my last slide. So this is the stepwise evaluation of chronic nausea and vomiting. This is probably the take-home message. In the initial assessment, identify the consequences of chronic nausea and vomiting and correct them accordingly: the dehydration, the acid-base electrolyte imbalance, and the nutritional depletion. Further assessment should be directed to identify a specific cause and treat accordingly. GI diseases such as mucosal disease, obstruction, hepatobiliary, non-GI causes such as medication, toxins, metabolic endocrine, CNS, and psychiatric diseases. So therefore, metabolic endocrine panel, abdominal X-ray, upper GI endoscopy, CT abdomen, small bowel series, CT MRI, and psychiatric evaluation as indicated. Then evaluate for specific causes to further targeted evaluation and treatment as indicated using therapy, very rarely an EEG or an antiduodenal manometer. And always the therapeutic trial of anti-emetics, prokinetics, and careful selection of patients for endoscopic and surgical intervention. So that's, you come to the end of the talk. I think if you have any questions and answers, you can post on the Q&A section and I will try to answer them. So there is a question that, do we have wireless motility capsule in Sri Lanka? To my knowledge, I don't think we have the variety that we have the most evident for. Is there a genetic basis for cyclical vomiting syndrome? Yes, there have been studies, and this is very closely related to migraine. So there is a genetic predisposition because there is a family history among these patients most of the time, but we don't test these patients for the genetic mutations. Oral erythromycin, yes, cannot be used because it develops tolerance so fast. Only the IV erythromycin can be used in hospitalized patients to treat acute severe nausea and vomiting. But it is useless. The oral erythromycin is useless as long-term treatment, and it is dangerous because it has its own antibiotic action. There is a question whether pregabalin or gabapentin both can be used to treat with visceral pain in these patients, and what should be avoided is the opioids. 24-hour pH testing in investigation of chronic nausea vomiting, probably, I would say no, because that would be indicated in absence of gastroesophageal reflux disease. If there is no previous documentation and we want to document reflux disease, a pH and manometry would be useful to assess the symptom correlation and before prior therapy for reflux disease. But as for a cause for chronic nausea and vomiting, the overlap is mostly with functional dyspepsia rather than gastroesophageal reflux disease. So I would say probably in the workup, no. Thank you, Manjula Caldera, for the comment. Yeah. Yeah, cyclical vomiting syndrome patients typically, I think Skolisha has asked the question, stereotypical vomiting occur exactly. They don't have to be exactly regular, but the vomiting periods can vary in duration, but there should be periods of complete resolution of the vomiting. That's very characteristic of cyclical vomiting syndrome, and each episode do not have to be the exact duration. There is a question as to what are the clues in the history for diabetic gastroparesis? Well, the patients are usually long-standing diabetics. It's more common in type 1 diabetes than type 2 diabetes because of longer duration of the disease. And the patients will have other features of autonomic dysfunction. They will have postural hypotension, they will have sexual dysfunction, and they will have gustatory sweating and features like that. They will sometimes also have diarrhea. So these are some of the clues as to diabetic autonomic neuropathy causing gastroparesis. I think I have covered the questions. I have not covered hyperemesis gravidarum, and I think most of the antiemetics are quite safe, except for the traditionally what we know, some of the ones that should be avoided. But ondansetron is quite safe. So is metoclopramide. If you go through the formularies, most of these drugs they will say to avoid, but as a general principle, they are not contraindicated, and it should be used for the shortest possible duration in the smallest dose possible. I think ondansetron is quite safe in pregnancy. Okay, in the absence of questions, I think we can wind up this webinar. And thank you for joining. Thank you very much.